Chapter 17, Pediatric Emergencies. All right. Sudden illness and medical emergencies are common in children and infants. And that anatomic differences exist between adults and children. That respiratory care in children is extremely important. General considerations. When managing a pediatric emergency can be one of the most stressful situations you can face as an EMR. You must remain calm and professional at all times. Unless you are prepared, your anxiety and fear may interfere with your ability for proper care. Parents can either be allies or the potential problem. Talk to both parents and the child as much as possible. Try and develop a rapport with children. Okay, kneel, squat, or sit down and establish eye contact and ask simple questions about pain. Be honest with the child. Some agencies provide the child with a trauma teddy or something to hold while they're being examined. Pediatric anatomy and function. Okay, the difference between adult and children's airways is the airway is much smaller in a child compared to an adult. A child's tongue is proportionately larger than an adult's tongue. Okay, you can see that from the pictures over there. Okay, pediatric anatomy and function. The difference between children and adults is the upper airway of a child is much more flexible than that of an adult. For at least the first 6 months of their lives, infants can only breathe through their noses. When demands on a child's respiratory system change, the child is able to quickly compensate, increasing breathing efforts. Infants and children have limited abilities to compensate for changes in temperature as compared to adults. Okay. As for everybody, we always perform a scene science up. Check for safety, your own safety first. Complete your primary assessment, your hazards, hello, help. Always check for levels of consciousness. Check for life-threatening injuries, breathing, pulse rates, things like that. Remember to adjust your pulse rate and breathing rate for children depending on the age. All right. Once you've finished your primary survey or primary assessment, complete a secondary assessment with a head-to-toe inspection. Always, while we're doing and asking questions, remember to refer questions to the child and to the parent. Try and get an accurate history of what's going on. Always do a thorough DOTS exam, deformities, open wounds, tenderness, and swelling. Look for bruising. Make sure that you ask for history of snapping sounds when bones and things like that are involved. Once we've got our medical history, we need to perform regular reassessments of the patient, checking your baseline vitals, pulse, breathing, skin color, temperature, pale, cold, sweaty, warm, flushed, dry. Eyes, are they equal and reacting to light? Are they pearl? And we need to reassess the patient regularly. If the patient is stable, every 15 minutes. If the patient is unstable, at least every 5 minutes. But I suggest talking continuously to the patient and continuously reassessing levels of consciousness and things like that, AVPU. All right, pediatric assessment triangle, we're looking slightly different. Okay, appearance, breathing, work of breathing, how effective is the breathing? Are they panting? Are they taking sufficient breaths or air to sustain life? Circulation to the skin, all these things can signify shock in a patient. Okay, appearance is an indication of how well the cardiovascular system, the lungs, and the central nervous system are working. Compare the child's appearance to what you would expect from a healthy child. Assess the eye contact, muscle tone, and skin color. Reassess regularly because appearance can change very, very quickly. Bit of a table for characteristics for appearance. Movement. Is the patient able to move vigorously or either limp and listless, but flaccid? Interaction, do they reach for the toy? Does the person make sounds, things like that? Or are they uninterested and almost unresponsive? Reassurance, reassured by caregivers or the EMS or EMRs, crying and agitated, unrelieved by gentle reassurance. Movement, follow the patient's eyes with a toy, or somebody, a moving finger, something they want to reach out and grab. If there's glassy-eyed stare into nowhere, you must know that's unhealthy reaction. Speech, age-appropriate, obviously, or mumbled, jumbled rubbish. And crying. Is it a strong cry, or is it just a whimper or high-pitched cry? Breathing work, things to listen for are normal, abnormal breathing sounds, noisy breathing, snoring type thing, crowning, grunting, wheezing. Sounds like a crackling branch, things like that. Abnormal positioning, leaning forward whilst using the arms to support them, like tripoding. Retractions above the collarbone when the ribs are depressed from the sternum, between the ribs and the sternum. Is it sucking in? Flaring of nostrils. Or they're trying to take deep breaths through their nose. Remember, they cannot breathe through their mouths. No? All right. Pallor is the skin pale, the mucous membranes pale. Okay, is there mottling, patchy discoloration caused by too much blood flow or too little blood flow, cyanosis, blue discoloration of the skin and the mucous membranes, fingernails, lips, inside the eyelids. Okay. Count respirations for 30 seconds and multiply by 2. Look for signs of distress. Assess how much work the child is having to do to breathe. Like I said, are they trying to use accessory muscles, trying to overexpand, looking for gasping for air, things like that. Look for signs of respiratory distress. Okay, check reactions on the neck and the chest and look for flaring nostrils. Again, pulse rate. Remember, normal pulse rate is different for a child. For a child younger than a year old, palpate the brachial pulse in the other arm, in other words. Breathing rates. Respirations, heartbeat, 90 to 180. Breathing, 30 to 60 breaths per minute. Infant, 1 month to 1 year, 100 to 160. 25 breaths to 50 breaths. Toddler, 1 to 3 years, 90 to 150. 20 breaths to 30 breaths. Preschool, 80 to 140 pulse. Breathing rate, 20 to 25. 6 to 12, pulse rate is 70 to 120. Breathing, 50 to 20 breaths per minute. Adolescents, 12 to 18 years old, 60 to 100 heartbeats. Okay, pulse, and 12 to 20 breaths per minute, same as an adult. High body temperature. High body temperature can be accompanied by a flushed red skin, sweating, profuse sweating, restlessness. To feel a high temperature, just touch the child's chest and head. Okay, the child's heart rate will increase with each degree of thermal or temperature rise. It is important to open and maintain an airway and to ventilate adequately in any child with respiratory problems. Some of the common causes with cardiopulmonary arrest in children caused by suffocation or aspiration of foreign bodies, choking on something. Okay, infections of the airway such as croup, epiglottitis, SIDS, sudden infant death syndrome, accidental poisonings, injuries to head and neck. All right, and asthma as well is one we can add in there. Always open the airway using the head tilt chin lift maneuver, unless, of course, you're concerned that there may be a spinal injury or cervical spine injury. Definitely, if there's a head injury, it's severe, we would be considering neck injuries as well. Do not hyperextend the child's neck when tilting the head backwards. Just open the airway gently. Okay, if there's a possibility of a head or neck injury, just try the jaw thrust maneuver. Basically, put your fingers underneath the chin, underneath the elbow of the jaw, and slightly lift it, opening the mouth in the process. Pull down on the chin, lift up the bottom of the jawbone. CPR for children is different to adults. If you're alone, emergency medical service is not being called, perform 5 cycles, 2 minutes of CPR before activating EMS. Okay, you must remember in your basic life support of a child, one hand, center of the chest. Compressions at 100 to 120 compressions per minute. performed in cycles of 30 compressions, 2 ventilations, ventilations 1 second each. Wait for the chest to rise and fall. Don't stop between your compressions at the bottom or at the top. Keep it flowing as smoothly as possible. And remember, we never want to stop compressions for more than 10 seconds. So if you can't establish decent ventilations, please continue to do chest compressions. Don't stop or wait for ventilations. Okay, respiratory emergencies. Continued CPR in infants is different from CPR in adult. Check for responsiveness by tapping the infant's foot or gently shaking the shoulder. Check the brachial pulse, just above the elbow on the inside of the arm, between the bicep and the tricep. Use the middle finger and ring fingers to compress the sternum just below the nipple line, center of the chest. Compress the sternum at least 1/3 of the depth of the chest, or about 2 to 3 centimeters, and give gentle rescue breaths. Only the air that you can fill in your cheeks would be more than enough to do this. Ventilations are maximum 1 second long. Wait for the chest wall to rise and fall before you give the second one. Always remember, when suctioning, be very careful. Okay, initially turn the patient on his or her side, and using your gloved fingers, scoop out any substances, saliva, spit, or vomit. Using a suction, remove the rest of the foreign substance, and suctioning can be a life-saving procedure. Remember, with an infant, 5 seconds maximum 5 seconds. With a child, maximum 10 seconds. With an adult, maximum 15 seconds. Only suction what you can see. Never force a tube down the patient's throat or anything like that. And beware of stimulating the gag reflex. Use a tonsil tip or rigid tip to suction the mouth. Use a flexible catheter to suction the child's nose. Okay, try and ventilate or re-oxygen the patient before repeating any suction again. Airway adjuncts. Oral airways or oropharyngeal airways or OP tubes can be used. Remember to correctly measure and insert the tube from the angle of the jaw to the center of the lips, or the earlobe to the corner of the mouth is a good estimate to size up. All right, remember inserting it upside down. Gentle, you don't damage the roof or soft palate of the mouth. When it's in far enough, make sure the OP tube is not caught between the lips, the teeth, and the tongue. Once it is in the whole way, turn it 180 degrees, thus caressing the tongue and bringing it forward, stopping it from falling back, and creating a bite block in case the child closes the mouth on any tube that you're using to suction with. Remember, in a partial or mild airway obstruction, place the child on his or her back, tilt the head, lift maneuver in the usual manner, remove any object that is clearly visible in the mouth and can be easily removed. If not, do not attempt to move the child as long as the patient can still breathe. The patient should be transported as quickly as possible to the emergency department. Ask the child if they can cough, maybe they can loosen it up. If you have oxygen available and trained to use it, place an oxygen mask over the patient's nose and mouth. Do not get an airtight seal. Hold the mask maybe an inch or two away, or 5 to 10 centimeters away from the child's face, and just get a free flow of oxygen past the child's face that they can breathe in. Severe airway obstruction is a very serious emergency. Okay, poor air exchange takes place, increased difficulty to breathe, silent cross, inability to speak, and no airway movement at all. All that's a very big problem. Okay. If back slaps, 5 back slaps aren't helping, patient can't cough, you might want to try gently using a Heimlich maneuver to try and dislodge or move any objects found in the patient's throat. Okay, revealing an airway obstruction in a child is the same as for an adult, with a few exceptions. When opening a child's airway, tilt the head back just past the neutral position. If you yourself are performing CPR or 5 cycles before the EMS, activating EMS. Okay. An infant is very fragile, just remember. If you suspect an airway obstruction, assess the infant to determine whether there is exchange of air occurring. If the airway is if the infant is crying, the airway is not completely obstructed, so air can still move in and out of the patient's mouth. If no air is moving, the patient's nose and mouth, suspect an object or an obstruction in the airway. Okay. Use a combination of back slaps and chest thrust maneuvers and assess the patient's airway for breathing, airway and breathing. Place the infant face down, position over one arm, support the head, neck completely. 5 firm blows to the middle of the back between the shoulder blades. Make sure the patient is facing down slightly to allow the object to come out a little bit easier. If this doesn't help, turn the baby over and apply 5 compressions to the chest bones, just below the nipple, center of the sternum. Okay. Repeat the steps until the object is expelled or the infant becomes unresponsive. Check again to see if you can see anything, and if not, begin CPR, starting with chest compressions. If the baby becomes unresponsive or the infant becomes unresponsive, ensure that EMS has been activated. CPR begins. Okay, with chest compressions, like I said, continue until personnel arrived. Okay, swallowed objects. If small round objects do not become airway obstruction, they usually pass and eventually to the child. Sharp or straight objects are dangerous if swallowed. Arrange rapid transport to the hospital. Respiratory distress. Signs of respiratory distress: a breathing rate of more than 60 breaths per minute in an infant, or a breathing rate of more than 30 to 40 breaths per minute in a child. Nasal flaring in each, and retraction of skin between the ribs and around the neck muscles, or stridor. Now, stridor, just to explain, is a high-pitched sound, usually when the patient is breathing in. What stridor represents is a partial airway obstruction. So you must remember with this, there is air moving in and out. Remember to remain calm. Okay, arrange rapid transport to hospital. Try unblock or remove the object by using some back slaps. Maybe if that's not working, we're going to do a bit of abdominal thrusts and try and dislodge this thing completely. Just remember, we don't want it to get blocked completely. So whatever you do, don't stick something down the patient's throat to try and remove this thing, unless you're trained to do so. Signs of respiratory distress. We can see definitely marked altered mental status, cyanosis of the skin, the blue color of the lips, the fingernails. Okay, very pale on the mucous membranes. Combativeness or restlessness. Sometimes if they can't breathe properly, they don't want to be touched, they don't want to be picked up, they don't even want to talk to anybody. Okay, obviously always try and determine the cause. Okay, and remember, children's respirations place the child in the most comfortable position, usually sitting. Okay, always check for things like anaphylaxis, things like that, especially with breathing in a child. If you notice swelling or the general signs of anaphylactic shock, itchy throat, okay, rash on the skin, difficulty breathing, okay, and then obviously the normal swelling signs and things like that. We need to monitor the child's vitals and arrange rapid transport to hospital. Okay. Okay, respiratory failure or respiratory arrest. By the time things have progressed, the breathing rate will be below 20 breaths per minute on an infant, 10 breaths per minute on a child. Muscle tone will be very limp, they'll be weak, unresponsive, decreased or absent heart rate, weak or absent distal pulses. Child in respiratory failure is on the verge of experiencing a respiratory or cardiac arrest. Okay, always monitor ABCs. Treat if you have oxygen, apply high flow rate of oxygen. Remember, for a child, use a pediatric mask. If you don't have a pediatric mask, just hold the mask by the patient's face. Okay, begin chest compressions if the heart rate is absent or less than 60 beats per minute, and arrange rapid transport to the closest hospital. Circulatory failure, okay. Most common cause of circulatory failure is respiratory failure. Can lead to cardiac arrest, indicated by increased heart rate, pulse, very fast, pale bluish skin, changes in mental status, okay, obviously decreased mental status, unresponsiveness eventually. If the heart rate is more than 60 beats per minute, okay, complete the patient assessment, just like we normally do, primary survey, secondary survey. Make sure that you get a good set of baseline vitals and support ventilation efforts. Administer oxygen, observe vital signs. The heart rate is less than 60 beats per minute. Begin chest compressions and rescue breathing. Okay, causes of altered mental state in children. Anything from low blood sugar, hypoglycemia, poisoning. Okay, post-seizure states, as in that post-ictal infection can be quite possible in children. Head trauma, decreased levels of oxygen from any cause. Okay, complete the patient assessment always with mental assessment, altered mental states. Pay particular attention to baseline vitals, initial vital signs. Keep the patient calm and the patient's family calm as well. Be prepared to support the ABCs, place the unconscious patients in the recovery position, and remember to get them to try and breathe, focus on their breathing nicely into the nose if they're able to breathe through the nose, slowly out through the mouth. Because infants breathe primarily through the noses, even a minor cold can cause breathing difficulties. Asthma is caused by spasm or constriction, inflammation of the small airways in the lungs. Usually produces a wheezing sound. Okay, calm and reassure the patient. Okay, put them up in a seating position. Burst the lips relieves some of the internal lung pressures. Try and encourage the patient to breathe out, blow up a bag or something like that. Help them to push the lungs out of the air so that they can get a fresh breath in. Arrange rapid transport if the patient has an upper airway infection or something like that. Between 6 and 6 months, it's usually something like croup, results in a hoarse whooping sound, inhalation like a seal barking, often occurs in colder climates, okay, where the lungs are getting cold there, and things like that. Croup or lack of fright and willingness to lie down are important signals and signs that distinguish croup from epiglottitis. If EMS unit is delayed, turn hot water on in the shower, close the bathroom door. Moist, warm air relaxes the vocal cords. Okay, epiglottitis is a severe inflammation of the epiglottis. The flap is so inflamed and swollen that air movement into the trachea can become completely blocked. Usually occurs in children aged between 3 and 6 years old who weren't vaccinated against epiglottitis. Okay, signs and symptoms. Child is sitting very upright, difficulty or can't swallow. The child is not coughing. Child is drooling, is anxious and frightened. The chin is thrust forward. And then your general signs and symptoms of choking would include things like difficulty breathing and things. Okay, make a child comfortable with as little handling as possible. Keep everyone calm. Administer oxygen. Remember, low flow rate, or just in a mask held away from the child's face just to try and increase oxygen. Arrange rapid transport to hospital. You must remember, in drowning cases, okay, caused by submersion in water, and initial cause is cardiac or respiratory arrest. The second most common cause of accidental death amongst children 5 years or younger in the United States. Do not put yourself in danger and attempt to rescue. Okay, always throw toe before you go. Okay, treatment, assess ABCs. Turn the child onto the side, allow water to drain out of the child's mouth. Use suction if it's available, and start breathing, rescue breathing if necessary. Administer supplemental oxygen. Flow, just if you can't have a face mask at the right side, just put it close to the patient's face. If no pulse is present, start chest compressions, stabilize the head and neck as needed. Remember, in an infant, the head is always bigger than the body, so the airway tends to close up. If doing it CPR on a solid surface, try and place something underneath the baby's shoulders to lift the chest and open the airway. Okay, to reduce the chance of hypothermia, dry the child, cover them with him or her with dry blankets, arrange rapid transport, and never stop doing CPR on a drowning victim. Okay. Heat stroke is a very serious, potential fatal condition in children. Okay, it requires rapid treatment. Remove the child's clothing, sponge the child down with tepid water, put a fan on them, fan them if you have to, wrap the child in wet sheets to speed up evaporation and the cooling process, arrange rapid transport to hospital. Okay, with high fevers. High fevers are common in children. They cause temperature-related breathing mechanisms in young children are not fully developed, and very high temperatures can occur very quickly. Most children can tolerate temperatures as high as 40 degrees Celsius or 104 Fahrenheit. Okay. With a high fever, we need to uncover the child so the body heat can escape. Okay, attempt to reduce temperature of the child by undressing them, fanning them down, using tepid water to sponge them down. Protect the child from a seizure and make certain that normal breathing resumes after each seizure. Okay. Okay, the seizures usually from high fevers or from disorders such as epilepsy, vary in intensity. During a seizure, the child loses consciousness, eyes roll back, teeth become clenched, and the body shakes with jerking movements. Very similar to grand mal seizures. Okay. During a seizure, the child's skin becomes pale and turns blue. Sometimes the child would lose bladder or bowel control. Place the patient on the floor or on a bed to prevent injury. Maintain adequate airflow after the seizure. Okay, provide supplemental oxygen if necessary, and if you're trained to do so, arrange rapid transport to hospital. Okay. With a seizure in the children, we always monitor the vital signs and support ABCs. Once the seizure is over, cool the patient if he or she has a high fever. And once a child has had a seizure, we always have to have them checked out by a doctor. All right, vomiting, diarrhea caused by gastrointestinal infections may produce severe dehydration. Okay, this can lead to hypovolemic shock and all other sorts of problems. Dehydrated children are lethargic and the skin is very dry. Hospitalization may be required to replace fluids and IV therapy. If you suspect dehydration, arrange rapid transport. Okay. One of the most serious causes of abdominal pain in children is appendicitis. Seen in people aged between 10 and 25, usually the child is nauseated, has no appetite, and occasionally will vomit. Treat every child with a sore and tender abdomen as an emergency and arrange rapid transport. Must remember when doing your secondary survey on a child and you are palpating the abdomen, there may be some rebound pain. Okay, poisoning in children. Ingestions of poisons are usually taken, ingested poison is taken by the mouth. Okay, anything going in the mouth is usually the most common or entrance of poisons into the body. Signs and symptoms could include chemical burns around the mouth, odors and stains on the mouth, nausea, vomiting, abdominal pain, diarrhea. Let's not forget things like burn marks in the skin and things like that. Okay, ingestion, abnormal or decreased respirations, unconsciousness, and seizures. With poisoning, we always want to try and identify the poison. Send a container to the emergency department. If you don't have an emergency department, phone the poison center. Try and identify everything that's going on. Explain very carefully what you found and see if they can advise you as to what to do if you're waiting for an ambulance. Gather any small tablets, replace them in the bottle so they can be counted. Okay. You may need to give the child large amounts of water or administer activated charcoal. Monitor the child's pulse and breathing and arrange rapid transport. Absorption is something that occurs through the skin. Localized symptoms may include a skin irritation or burning, contact dermatitis, something like that may cause hives, itchiness, swelling on the skin. Systemic signs and symptoms include nausea, vomiting, dizziness, shock, altered mental status, things like that. Ensure that the child is no longer in contact with the poison substance. Protect yourself, obviously, from the poison. Remove the child's clothing if it's contaminated. If the patient has got a dry chemical powder on them, brush them off and try and rinse the water for it, rinse the water for at least 20 minutes. If we can identify the poison, all the better. Okay, monitor for changes in respiratory, ABC. The child has vomited, save a sample and send it to the hospital, arranging rapid transport. Okie dokie. Sudden infant death syndrome, or also called crib death, is a sudden and unexpected death, apparently, of a healthy infant. Usually occurs between the ages of 3 weeks and 7 months, and adequate scientific explanation does not exist for SIDS. Be compassionate with parents. Remember, once again, if the baby is still warm, use CPR and continue until help arrives. If the patient is dead, do not mistake large bruise spots on the side for abuse. Blotches are caused by pooling of infant's blood at the bottom of the skin, the lowest part. Follow the protocol for the deceased Spanish patients. Pediatric trauma. Trauma is the #1 killer of children. Treatment of an injured child as you treat an injured adult, but remember following differences. Children cannot always communicate the symptoms as well as an adult can. A child may be shy and overwhelmed by adult rescuers. Always try and establish a good communication or rapport with the child. All right, you may need to adapt materials and equipment for the child's size. A child does not show signs and symptoms of shock as easily or early as an adult, but can progress into severe shock quickly. Injury patterns on a child sustained should be related to 3 factors: the type of trauma they've experienced, the activity causing the injury, and a child's anatomy. Okay, motor vehicle crashes. Unrestrained patients have more head injuries and neck injuries than those that are restrained. Okay, and restrained patients often suffer head injuries or spinal or abdominal injuries. Bicycle accidents. Children often suffer head injuries, spinal, abdominal, and extremity injuries. The use of bicycle helmets can greatly reduce the number and severity of head injuries. Okay, when a child is hit by a car, they often sustain chest, abdominal, thigh, and extremity injuries. Falls from a height or diving accidents cause head and spinal injuries and extremity sometimes. Okay, burns are a major cause of injuries in children. Boiling water, fire, things pulled down on top of them, hot oil, things like that. Sport injuries cause a wide variety of injuries depending on the type of sport activity. Okay, regardless of what caused the injury, check the patient's airway, breathing, and circulation. Always remember, severe bleeding, hemorrhage is always a source of concern. Treat the patient for shock. Conduct a full body secondary assessment, head to toe. Okay, follow the dots and sample procedure, getting as much information as you possibly can. Stabilize all fractures, injuries, dislocations. The patient has head lacerations, treat the wounds with direct pressure and bandaging. Just remember, anytime you treat a head injury, don't apply too much pressure. Make sure that there is not a skull fracture involved when there's bleeding on the head and face. Children show shock symptoms much more slowly than adults do, but can progress through the stages of shock extremely quickly. Signs and symptoms of shock are present in a child, and a child is already in severe shock. Remember, very quickly, cold, clammy skin, weak, rapid pulse, shallow, and rapid respirations. Okay. Traumatic shock in children. Seizures are relatively common in children who have sustained serious head injuries. Greatest danger for airway obstruction and hemorrhage. Okay. Open the airway, maintain it, control bleeding as quickly as possible, and arrange rapid transports to hospital. If you find a child in a car seat that's injured, okay, make sure that you The seat is removed from the crashed motor vehicle. Leave the child in the seat until the ambulance arrives. In some cases, a child can be transported to hospital secured in the car seat. Stabilize the head and neck. Okay. Be concerned if the child is withdrawn, fearful, hostile, or unwilling to discuss how injuries are caused. Always treat child injuries, and if you suspect abuse, ensure the child's safety. Okay. Always remember to treat the child first, give it your best things, and after you've treated the child and made sure that there is no danger to them, then you can always consider contacting the police, child services, things like that. Abuse in children, usually bruises in various stages of healing, human bites and burns, reports of bizarre accidents, multiple fractures. Okay. Also, if I can add, fear of adults and things like that. We always just want to make extra sure of what we're doing. Never say anything, never suggest anything, but always make sure you get the correct help that that child needs. Okay. If you need to transport a child, if the parents object, summons law enforcement. Okay, always get the right, correct law enforcement involved. Signs and symptoms of neglect, lack of adult supervision, malnourished appearance, unsafe living environment, chronic illnesses. Yeah, always a problem, eh? In addition to experiencing sexual assault, children may have been beaten and may have other serious injuries. Obtaining information from the child and any witness and provide caring approach. All sexual assault victims should receive transport to the appropriate medical facility. If you suspect any sort of sexual harassment or anything, always try and transport them as soon as possible and make sure they're safe. Treat the patient